Hi, everybody, and welcome to this very special episode of the Dr. Keith Darrow podcast, where today we welcome renowned otolaryngologist, Dr. Jed Grisel. Dr. Jed, how are you?
I'm doing great, Dr. Darrow. Thank you so much for having me on the show.
No, it's great to have you here. Look, you're this sort of, you've got private practice, you're working with Amplify, you understand the connections of cognition and hearing. I mean, you're doing so much cochlear implant work. I've been snooping around, reading some of your research articles that are out there. I think you've really got your sort of finger on the pulse of where hearing healthcare, where otolaryngology needs to go. And so I really wanted to have you come on here and share a little bit about your story and how you got to here.
Well, thank you. Thank you, Keith. And I appreciate you having me on. And I'll tell you, the common thread between all of this stuff is that I really am passionate about hearing loss. And I'm passionate about the role that hearing healthcare providers can play in this whole cognitive awareness that we now are having. So I just, want to start out by thanking you for all the work that you do of raising awareness and helping to push the needle forward in terms of what we're doing in that space. So appreciate that.
No, definitely. It needs to happen. There's 42 million people sitting on the sidelines that need our help. And I have to say, if I could add to the 42 million people, I think there's too many, maybe primary care physicians. There's even some otolaryngologists, I say that respectfully, who aren't necessarily embracing this concept of how important hearing health is for cognitive health.
And how important hearing health is for an aging America in general, for quality of life. And I take that with otolaryngologists. I'm in a practice with many of my colleagues who this is a daily discussion that we have of bringing this. And I'll tell you that I think that this is the day for the audiologist. I think that this is a time where audiology gets to take the helm as leaders in this space, because they are the professionals that manage this issue. And so I have, all of the respect and friendship with many of my audiologist colleagues. And I think that this is one of those scenarios where medicine and history are combining for this to be a golden age for audiology as a specialty. And I'm very optimistic for the specialty of audiology as we move forward.
I completely agree, right? This goes so far beyond the widget, right? I think we've been forced a little bit into this scenario. I think between disruptions from outside, plus the data that has emerged in the past decade about hearing loss, about cognition, I think it's the perfect mix of, okay, I love your example. Let's take this, by the reins, let's be at the helm, and let's really push forth and help Americans actively age, right? Because we know you talked about quality of life. We'll get into reducing the risk of cognitive decline, experiencing less tinnitus, staying more independent, staying in your home longer if you can avoid a fall. There's so much to proper hearing healthcare that, we've got to get the word out.
Yes, sir. Absolutely. Well, just to kind of give you a little bit of background about myself. So my name's Jed Grisel. I'm an otolaryngologist. I am a Texan, not by birth, but I got here as quick as I could. And, I did my training in Cincinnati, Ohio, with Miles Pinzak, who is a well-known neurotologist. That's where I learned how to do ear surgery. And I loved my time there, but we got back to Texas, and I've been here for about 10 or 11 years. In my day job, I'm an otolaryngologist. I see patients just like every other otolaryngologist out there. I'm part of my practice in Wichita Falls is part of a larger network of ENT clinics in Texas called ENT Specialty Partners. So we have 14 locations throughout Texas, and we're growing, 21 doctors, 15 audiologists, and we're expanding. And so we're really trying to push the limit of what otolaryngology clinics and otolaryngology especially can do. And so that's all great and wonderful. Cochlear implants are a big part of my life. I do probably about 60% of my practice is hearing loss. And I love seeing people be able to hear. Right. So that's what sort of got me into this. I think that what I love about our specialty is we help people connect with the world around them. We make we make life better for folks. Some of the research that I've done has been in cochlear implant outcomes. So we've created a database for cochlear implant outcomes and published quite a bit on that. And so that's the ENT side of my life. So when it comes
if you don't mind me asking though, is
Sure.
there something more personal to it? How does one get down that track? Look, I'm always upfront. I tell people my mother suggested audiology and I do what my mother tells me to. I don't have, that sort of, I don't have one of those pull at your heartstring stories, but I was wondering if maybe you do, or if this was personal for you, or,
I don't have a family member who's had hearing loss. So my undergraduate degree was in biomedical engineering. I love technology and I love toys and I love, the signal processing aspect of audiology and that sort of thing and hearing loss. And so ENT was a very natural fit for me because of all the toys that we get to use. But then seeing all that technology used to make people's lives enriched is just gratifying, right? And so I've just sort of fell into it and I love it. So that's kind of the background there. So when it comes to Amplify, you mentioned Amplify. So in addition to seeing patients on a regular basis, I serve as the chief medical officer for a company called Amplify Hearing. Amplify Hearing is a fabulous group. It's a company based out of the United Kingdom, and it's the fastest growing hearing company in England.
Okay.
So one of the things they figured out in the United Kingdom is that vision and hearing go well together. About 12 years ago, the UK was like the US. We had tried it in a few spotty places. They had tried it in a few spotty places, sort of with minimal success, and then some of the big vision companies started putting hearing, and they realized, like, goodness, this is a natural fit, right? Like,
sure.
There's patients here with dual sensory loss or sensory deprivation. It's a good fit for people. The patient flow of getting people, like optometry has done a really good job of getting patients to come back on an annual basis for sensory checks, which we don't do as good at that on the hearing side.
Yeah. Yep.
And so they've figured this out and done really well. And so Amplify is it's a group that what we specialize in is putting audiology into the optometry space. That's what we do, and we do it really well. And what's different about people?
Well, all right. So let me just stop you there. There's going to be naysayers, right?
Yeah.
Because what I just heard you say is, Pearl Vision now sells hearing aids.
Mm-hmm.
But that's not really the model. So tell me more about that, just so we can dispel, any of those rumors. Look, I know you've experienced that people in this industry don't like change.
Yes.
And so when they hear that, they may be a little,
well, look,
might be a little pushback.
Yeah. So the thing that's unique, I will say that there are some groups, even in the UK, that follow that model. They think it's as simple as, oh, we're selling glasses and doing eye exams, let's just start selling hearing aids.
Yeah, I saw them all over Paris. I saw the, the eyes and the ears were like right together.
Yeah. And that, the thing that people miss then, that you and I know very well, is that, audiology is not a product, it's a specialty, right? It requires a health professional who's involved. And so where people, I think, have failed at this, of combining vision and hearing, is that they try to oversimplify it, and they try to commoditize the audiologist.
There you go. Yeah.
So they try to hire an audiologist, plant them in a room, and just say, oh, just sell hearing aids. And that's the opposite of what we're about. What's really unique and what's so joyful about working with the Amplify group is that the way that we go about this is we create opportunities for audiologists to own their own business. So instead of us going to an audiologist and saying, we just want to hire somebody and put them in this spot, we recognize that they are the sort of the consummate professional in this space. And we create what we call joint venture partnerships. So we bring them as equal partners into this business. And then we go and we insert a service line that we manage together with the audiologist for the optometrist. It's not selling a product, it's inserting a managed service line.
Okay.
And it's doing it in such a way that creates these just wonderful opportunities for audiology. And we've launched recently in Dallas. Dr. Guerra is our audiology partner there. Okay. And here's a fabulous audiologist who's a few years out of school, who now owns her own business.
Wow.
And a lot of audiologists may have the interest of owning their own business, but they may not have the, risk tolerance to take out loans.
Well, I think there's risk tolerance and there's complete lack of business education in an audiology program.
Right. Like, and same in medical school, right? We don't get the training on, how to read a balance sheet. How do you create contracts with the manufacturers? How do you, do marketing? How do you do all these different things? And so what Amplify brings to the table is we find the optometry groups, make sure they're a good fit and they understand the vision of what we're about. We do the back end business support, marketing, getting equipment, manufacturer contracts, all those sorts of things so that the audiologist is successful. We create the patient volume, and then we really prop up the audiologist so that they can do what they do best, but doing it in a way where they have ownership in the process.
Now, is there a role for ENT or otolaryngology in this, or this is really separate from your quote unquote day job?
This is separate from my day job. Gotcha. And this is there is a role for, so, there are audiologists that really thrive in the ENT space, sure, where they do more sort of tertiary diagnostics and that sort of thing. This is a little bit different, and it really is a separate sort of beast of what we're building. We are in 2 weeks launching in Austin, Texas, with several groups there, and then we have opportunities all over the East Coast. That we're
well, I've seen that one. It might just be because of my location, but I've seen the marketing for an audiologist on the Boston South Shore, which is maybe 35 minutes from my house. And I wondered, what's opening up there? Is it a medical shop? Is it retail? Sounds like it's obviously more medical based. Is it connected with different affiliates? Like, how does it work?
Yes. So the way that it works is the way that we identify the optometry clinics can come in multiple different forms. This one in particular is, we don't go to chains. We don't go to Pearl Vision. We don't go to America's Best. Mm-hmm. Where we go is the independent optometrist who has a little bit more of a, I would say, boutique or medical bent. And so there's a group, there's a really successful optometrist in the South area of Boston who's got 4 locations and adding more, and is ready to, if you're an audiologist listening to this and you're in that South Shore area, you'll be busy from day one. Right?
That's excellent.
And have that. So that's the opportunity there. We have,
and it sounds like, is it all practices where you work towards ownership shares or something like that?
What do you mean, Keith?
Well, you said something about ownership, about becoming you become an owner as time goes on.
Well,
is that all of these, or?
Yeah, we only do this. We don't employ any of the audiologists. What we do is we create a business in every entity where we go. We create a business, and that business is 50% Amplify, 50% audiologist.
Excellent.
And then so they are equal partner in that business. And then we together create an entity that we go in and then insert this into the optometrist. And then there's some ways that the optometrists get some stake in it, but
sure, of course.
So it's a team, right? It's a team effort, and it's successful and it works well. And so that's,
and I would imagine you're finding this easier than just opening up another audiology practice on Boston South Shore or Austin or wherever.
Well, look, we go with optometrists who are known and respected in their communities, have legacy, reputation, and patient volume. Right.
There you go.
And so these optometrists, and if we go to an optometrist and we don't feel good about it, that they're doing the right thing by their patients, then we move on. Right. Okay. And so that's how it works.
That's fantastic. What an interesting concept. Is that, is there a projected, 400 practices in the next 10 years? What are you looking at? What's the goal?
So in the UK, they've been in operation for about 4 or 5 years.
Okay.
And they have audiology in over 200 locations. And they'll probably add 100 more this year. The audiologists in the UK are really lining up to
Mm.
join this movement because, historically, people, they're not working for, no offense, they're not working for a manufacturer, right? They're working
Yeah.
for themselves. They're
Yeah.
not working for an ENT doctor who's employing them. They're working for themselves. And when we treat our audiologists as business owners and with respect, and as very important members of the team. And I think people like that. We had the chance to go over and spend a week with them at their annual retreat.
Sure.
And it was such a refreshing, fabulous experience to sit in a room with these audiologists, and they all have varying levels of business expertise, but what they all want is they want to do a good job.
Yeah.
And some of them will service 2 optometry clinics. Some of them will service 6 or 8. Right. And
Okay.
so sort of their opportunity to grow is only limited by their ambition. Right. And we'll help them achieve that goal.
Interesting. I mean, it's such an interesting model. I do look forward to sort of watching that. Look, I come from really one really simple standpoint of there are 42 million people that need help. There's not enough of us. There needs to be more hearing healthcare providers than there are baristas at Starbucks, right? And then if 10% of people living with hearing loss decided tomorrow that they wanted treatment, every one of our practices would have a wait list probably 6 years long, right?
Yeah.
There's just not enough of us. The universities aren't putting out enough. So any opportunity, and I love the combination, right? Eyes and ears, both probably the 2 most important senses. And what we know, I know you probably, you've reviewed this with your patients, losing both vision and hearing increase the risk of cognitive decline and dementia.
Absolutely.
So it really goes together nicely. And has that been some of your sort of motivation? Because I do know in addition that you've been a real proponent of cognitive screenings in hearing healthcare.
Absolutely. So this is my take on this, Keith, is that, if we all know that hearing loss is this, profound modifiable risk factor for dementia development. And but if you read the Lancet study, it's not just treating hearing loss at any time, it's identifying and treating in midlife, right?
Yes.
It's during that mild cognitive impairment phase. So if you and I, and this gets to the paper that some of the research I'm doing with Dr. Beck, is that if you and I were to send a patient tomorrow to our local neurologist and say, this patient has mild cognitive impairment, they're going to look at you and say, well, what do you want me to do about it? Have they had a stroke? Do they have dementia? Do they have, they're going to say, well, what do I do? Right. If we're going to go to the primary care office and tell them you need to start screening people, they're going to be like, I'm just trying to manage diabetes and high blood pressure and do all the government required checklists that I have to do in my 15-minute slot.
And now you want me to do a screening for which I can't prescribe a pill.
Exactly. And so the question becomes then, if we have, all of these folks who have mild cognitive impairment, and we have the opportunity during that window to make a difference, who in the healthcare system is positioned to identify those people, right? It's not primary care. It's not the neurologist. It's not the dementia specialists, right? And so as we've looked at this, we've said, well, those who interact on a regular basis with patients with sensory deprivation, vision loss, hearing loss, we are actually in a very unique situation because there's a high, if you have vision and hearing loss, that sensory, degradation shows that you're at risk factor for some of these other cognitive degradation. So we are already self-selecting a group in our regular practice who have high risk. Plus, if we identify someone with mild cognitive impairment, we're in this unique position to actually make recommendations that can alter their trajectory of dementia development. And so to me, I just feel really strongly that audiology and otolaryngology, that we're doing a disservice to our patients if we're not bringing this up with them.
Yeah. Yeah. Now, how do you see the otolaryngology practice using this? Is this something that you've you're arming your audiologists with? What role are you playing as the otolaryngologist in this? Because there's definitely, there's some, I've heard grumbles within audiology of, is this our scope of practice? I'm a firm hell yes on that
Yeah.
one. But
Yeah.
now it's otolaryngology. How do we work together? And what do you see the role of the otolaryngologist in this?
So, yes, and that's a great question. So pulling away now from my Amplify hat, putting back on my otolaryngology hat. So
Sure.
the way that we do this in my practice is every patient. So we don't do a cognitive screen in a busy, regular ENT clinic when I'm seeing patients with sinus disease and, thyroid problems and all the other stuff, right? But any patient that I see in my regular clinic that is sent for evaluation of a hearing intervention, whether that's hearing aids, Baha, cochlear implant, any patient that gets sent from us to our audiology department for a hearing intervention evaluation, we do a screen on
Okay.
every single one of those patients. There's a lot that we still need to figure out, and I understand that we're on the front edge of figuring out some of these things
Sure.
out.
Sure.
But what we do is we do a screen on those patients, and that helps us understand before we embark on this journey, whatever it is, whether it's a hearing aid, cochlear implant, we want to understand what top-down processing skills that patient is starting the journey with. And it has so many important counseling benefits for us. One, if the patient's struggling with their hearing intervention, it gives us some explanation or reason why that's the case. It tips us off to patients that might need additional resources. It also, if the patient is really performing very poorly and they're not improving with treating their sensory deficit, then we can get them in touch with, usually it's their primary care physician.
Sure.
Would be the next step for us. So we're using it on every single patient, and it's part of our routine.
And and I love what you're saying there, because a lot of people are thinking of it. A lot of people have this fear of, well, as I said, scope of practice and diagnose. No, first off, we're not diagnosing. So let's just put that one to the side, right? We're doing a screening. And the screening, I think, has twofold implications. One is it makes the recommendation for intervention that much easier, right? You've got good cognitive skills. Let's keep them that way. You've got, poor, or there's an issue with your cognitive skills. Let's see if we can get them better, right? So I think it lends itself to helping the patient understand the importance of treating their hearing loss. And then I love what you said, which is, and not enough people are thinking about this, which is, what if your patient's having an issue, right? And so what if there's a executive functioning issue? What if there's a memory issue? I mean, that might be why your patient isn't being successful at actually wearing their hearing aids, at doing the exercise, whatever it is you've recommended as part of their treatment plan. They may not be doing it, dare I say, the right way.
Hey, I tell you, if an interesting exercise is to review the list of medications that can cause cognitive decline. Right, the list is long, and if we have a pretty decent elderly population in our community, and polypharmacy is a huge problem in America of people getting on all of these medications, and they're on, you read them and they're on 6, 7, 8 medications that all can cause cognitive decline. If I do nothing else for my patient than help them hear better and simplify their medication list through their primary care doc, I've done wonders for that patient, right? And so I think that we can help with that. And so the question, we hear this about scope of practice and diagnosing and all these sorts of things, but look, so ENT has had a long history of collaborating with other professionals in which we are not the primary expert, right? Mm-hmm. Like, let's take, for example, endocrinology. We are the thyroid surgery experts, but when it comes to nuanced endocrine disorders, that's not us, right? So we see patients and then we work together with an endocrinologist. We do this in head and neck cancer. We manage the surgical aspects of head and neck cancer disease, and then we work with the oncologists who manage the medical oncology and the radiation oncologists who manage the radiation oncology. So it's silly to think that in a world as intricate as us, that we have to, that we should, not care about anything that is adjacent to our specialty, right?
Sure.
And so that's the way we approach this. We're not cognitive health specialists. We're not practicing cognitive medicine, but to practice audiology and ignore the cognitive aspect, I think, is not appropriate in 2022.
No, it's not. It's still, we're 11 years past the data from Franklin and John Hopkins.
Right.
And the fact that only because I know some of the people at CogniView, I believe the number is something like a 10% penetration rate, meaning 10% of hearing healthcare providers are regularly doing cognitive screenings. I would imagine, respectfully, the number is probably at 2% when it comes to ENT practices.
I would agree with that.
Yeah. I would be curious. Would you share, we don't have to say names, but yeah, I think you said there's 21 ENTs at your practice?
Mm-hmm.
What have those discussions been like? I'm finding it hard to believe that all 21 are like, yes, cognitive screenings, let's do it. So what's that like sitting around the break table?
Well, we have presented this to our entire group of clinicians, and people are it's sort of like a dog sniffing at something, you know. Okay. People are interested. They're checking it out, but they're not biting on it. And so we've done some pilots in different groups. And I think what needs to happen is we need to get a little bit more data on and a little bit more clarity around what is this, how does the screening impact? You know, I care about this and I'm passionate about it. And my audiologists here in Wichita Falls are. So we've sort of got this vibe going and we use it in our counseling and we feel like it's very important. But I think we need a little bit more data and a little bit more explanation about exactly how it fits as an integral part of what we're doing. I think that some of the audiology professional societies could help if we say, look, cognition is part of hearing, right? And if you're not, as an audiologist, if we're not measuring that, we're really not doing our specialty, right?
We're not following best practices. We're potentially harming patients where, you know, it's just not right. I'm with you.
You know, one of the things that we found is on our cochlear implant side, and this is an example of, I think, how it can get integrated in a more meaningful way, is that what we're finding is that if a patient starts their cochlear implant journey with good skills, we feel very confident that we're going to help them improve their speech and quiet and their speech and noise, but their performance on those tests. If they start off and their cognitive skills are struggling, those patients, we tell them we feel pretty confident that we'll help you with speech and quiet. Speech and noise requires a lot of those skills that you're lacking, and we can help you with audibility, but that speech and noise we may struggle with. And we have that discussion with every single patient. And if I didn't have the CogniView results, I wouldn't be able to have that as meaningful of a way.
So I hope anybody who listens to this will take the last 2 minutes of what you just said and literally cut it out and play it on repeat all the time. Because at least in my field, as long as I've been in it over 20 years, there's always been this sense of setting realistic expectations. And if you ask most audiologists, well, what does that mean? They'll tell you, well, make sure you tell the patient a hearing aid doesn't cure them and it doesn't, they're still going to have to do this in a restaurant and face people and I get all that. But now we have a tool that can help us actually set realistic expectations based on data. So not only do we have tests like speech and noise, which I know you mentioned Doug Beck, which has been his, charge for the last 20 years. How can we get more audiologists, hearing healthcare providers to assess speech and noise? Because it really tells you more about the cognitive side of hearing. And now we have another tool, and we really are doing a disservice by not using the tools that have been provided to us.
Absolutely.
So let me ask you now. This wasn't intentional, but I love your analogy with the dog sniffing but not biting. We're both on this panel, the 2022 Cognition and Audition Summit. What I'm hoping to get out of it is more bites, right? Because as I said, in my field, 10% are using some form of cognitive screening, are using cognitive view tools. I really think the other, at least 80% of them are interested, but not biting. What do you think needs to happen to really change the hearts and minds in hearing healthcare as an outsider, semi outsider?
As semi-outsider. Well, I think it's important to remember that there's this interesting dynamic. I'm speaking right now in the ENT audiology space, right? How can we get more audiologists that practice within ENT clinics? How can we get more of them screening and bringing cognitive health into their practices? And I think it's important, if you're an audiologist listening to this, to remember that in your practice, you are the hearing expert, right? Your ENT colleagues that are in your practice spend a lot of their time thinking about a lot of other things. And the unfortunate thing is there's this interesting dynamic in which in many practices, the decisions on what you do are made by the ENT clinician, but the audiologist is the one that's the expert in this. And so, so I think that what we need to do is be vocal, right? I think if you're an audiologist and you have wrapped your mind around this science and the value that we're bringing to patients, I think it's important to speak up and say, look, because we as ENT doctors will take the lead, but we need to have a rational reason why we should do it, right? There's, nominal cost, there's some change in workflow, whatever, right? Like
whatever.
If it's the right thing for patients, we as ENT physicians, I think that we want to do the right thing for our patients. We just want to justify it, right? And so sure. I think being vocal and bringing this evidence to light in your practice is really important, and not being, and doing it on behalf of your patients. I think that getting some best practices around this, mm-hmm. so that if you're not doing it, you're actually practicing out of date medicine is really important. And I think we need to do that within our respective societies. Right?
Sure.
So I think that those are some of the things that we can do to get people to buy it. And I think just like any innovation, I think it's going to be, there's going to be the people that push for a while, and then all of a sudden everyone will have wanted to do it yesterday. Yeah. And I can see the sort of critical mass building, and it's happening, but we're not quite there yet, but we're getting there.
So, and I love that. And I think that that's really a big sort of introduction to what is this cognition and audition summit, right? I'll tell you what I'm speaking about, and then I want to hear a little bit more about you, but I think you just hit the nail on the head with the implementation. So at this event, which is in October, it's in Dallas, it's at a great location. It's a nominal fee for you're going to get 7 CEUs, which is just incredible, whether you're in AAA or in IHS. So I'll be talking about sort of the underpinnings, the neurophysiology of how hearing loss impacts the brain and how it just makes sense. I feel like most of us, once Dr. Lim put out the data, it was like, yeah, we knew that in our gut, but we didn't really have the data. And so I want to walk through some of what I've studied for 20 plus years, looking at countless numbers of brains and what happens to the brain as we age with hearing loss. And then I know Dr. Doug Beck will be giving his sort of perspective on how audition and cognition, how they go together. Dr. Jill Davis, who's also coming on the show in a couple of days, she's going to be talking about the actual implementation, boots on the ground. And what do you plan on talking about? Give us a sneak peek of what you're going to go through.
So first of all, I know and respect Jill very well, and I'm glad she's coming on the show. And I'm really excited, if nothing else, just to hang out with you guys and spend some time together, because it's a great group of people. And so Jill's going to talk a little bit, because I've heard some of her talks, before, and about sort of the real world implementation. And she's a freestanding audiologist, right? But then there's this whole other world of ENT audiology. And so that's what I'm going to try to talk about. I'm going to talk a little bit about the rationale for why otolaryngologists should be considering this, and why they should be supporting and empowering their audiology colleagues in their practice to be doing this.
Excellent.
We're going to talk a little bit about some data that we've seen about the feasibility and acceptance of patients and hearing professionals, because we've done some work on this, and this is part of the paper that Doug and I are working on of, if you include this as a routine part of the comprehensive hearing assessment, how do patients respond, and how do hearing professionals respond? And we have some multi-center data that we're going to share there, and then we're going to just talk about some real world sort of nuances of how we do it in our practice, and how we use the data and how it makes a difference for our patients.
Excellent. And for those of you who are listening, there's going to be an entire, I think it's about 1.5 hour CEU, a hands-on workshop, because I know that that's one of the things that people are sort of intimidated by. And we're going to review sort of, I hate the word scripts, but we're going to review how to introduce it to patients, how to walk them through the process, how to help them understand the results, what to do with the patient, right? I know, like in the description of your talk, it's, your patient is at increased risk. Now what, right? Yeah. What do we do about the management of this patient? And I know we touched upon it a lot during this talk, but it's going to be a real fantastic event. I know we're already close to about 50% sellout, so that's always good.
Well, if you're listening to this, we would love to have you. I think it's going to be a great opportunity for all of us to learn together, share some good information, and continue to move this forward and gain momentum.
Great. Dr. Jed, I thank you so much for your time today. This has been fantastic. You've shed so much light for me on looking at the future of combining eyes and ears, which just make so much sense in the elderly population, and really coming to understand the role of cognition, audition, and how ENTs, hearing healthcare providers, how we all play a role in helping to improve our patient outcomes. Thank you so much.
Thank you for having me on. This has been great.
Yeah, thank you, Jed. Take care.
All right. Have a good evening, everyone. Thanks.